A lot has stopped in the world, but you can count on Janssen to keep developing and producing the medicines you need. Janssen is the pharmaceutical companies of Johnson & Johnson.
Hello, everyone. Good evening for those in my time zone, and also good morning, good afternoon for the others. I'm Daniela Filipescu. I'm a cardiac anesthesiologist and intensivist in Bucharest, in Romania, secretary of the World Federation of Societies of Anesthesiologists, and member of the steering committee of the European Sepsis Alliance. I welcome you all to the World Sepsis Congress, to the fifth session of this amazing event. And I want to thank to our exclusive sponsor of this session, Janssen. I'm very honored to chair this session on standards and novel approaches to prevent sepsis. And I am very happy to listen to the 6 presentations given by well-known scientists. You can read the short bios of the 6 presenters on our website. And I have a great pleasure to introduce the first speaker, who is Dr. Padmini Srikantiah. She is a senior program officer in global health at the Bill and Melinda Gates Foundation. Priorly, she worked for the US CDC as a senior medical epidemiologist and also in WHO Southeast Asia Regional Office, and she was focused on antimicrobial resistance and HIV drug resistance surveillance and prevention programs, respectively. Dr. Padmini was trained in internal medicine in Cornell University Medical Center and infectious diseases at the University of California in San Francisco. Please, Dr. Padmini, you have the floor.
Thank you so much, Daniela, and it's my pleasure to speak with all of you. Good morning, good afternoon, and good evening. As Daniela mentioned, my name is Padmini Srikantiah. I lead the antimicrobial resistance strategy at the Bill and Melinda Gates Foundation in Seattle. I would like to thank the organizers for the opportunity to speak at the World Sepsis Congress, and it's my pleasure to share some thoughts today about emerging vaccine targets for sepsis in a global health setting. In the context of sepsis, I will focus on the most vulnerable populations where we at the Gates Foundation focus most of our efforts. In particular, I will start with neonatal mortality, while maternal and child mortality have halved worldwide in the last 2 decades, the reduction in neonatal mortality has been slower, and the number of neonatal deaths in low and middle income countries remains unacceptably high. In 2016, close to half, or 46% of under 5 deaths occurred in the neonatal period, the first 28 days of life. When we dive further into the causes of neonatal death, we see that 1/4 of neonatal deaths are due to infectious causes. These infections are causes of not only increased neonatal mortality and morbidity, but also can be causes of stillbirths, maternal morbidity and mortality, as well as excess hospitalizations. Increasingly, as I will show shortly, these infections are due to difficult to treat drug-resistant pathogens. For these reasons, our foundation's antimicrobial resistance strategy is focused on prevention overall, with vaccines as a central pillar. This encompasses ongoing work on vaccine development and delivery that has been the mainstay of our global health work in enteric diseases, pneumonia, TB, HIV, and malaria. But the key focus of our AMR strategy is on prevention of neonatal sepsis, where we are most concerned about excess deaths due to drug-resistant pathogens. This work takes shape in two key pillars: evidence generation and surveillance to better understand etiologies, resistance patterns, outcomes, and burden of neonatal sepsis in low and middle income countries. And the second is to use these data to inform product development efforts that are focused on prevention of these infections. The approaches include vaccines, monoclonal antibodies, microbiome-based approaches, and innovations in facility-based infection control. For today's talk, I will focus on our interest in vaccines, which is, of course, also our primary interest. So from surveillance, what do we know about neonatal sepsis in low and middle income countries? A recent systematic review focused on Africa included 151 primarily facility-based studies from 26 countries. About half the studies included microbiological data, and these studies identified several key pathogens that accounted for an outsized proportion of infections. Chief among these are Staphylococcus aureus and Group B streptococci among gram-positive pathogens, and Klebsiella pneumoniae and Escherichia coli, or E. coli, among gram-negative pathogens. The investigators further compared etiologies reported in an earlier time period between 1980 and 2007 to those identified between 2008 and 2018. And notably, high levels of antibiotic resistance, particularly to first-line empiric treatment for neonatal sepsis, was widely detected in this later time period. For this reason, the high prevalence of AMR highlights, of course, the need for access to effective antibiotics for these vulnerable populations. And we can all certainly agree with that need. In the long run, however, the deployment of new antibiotics always carries the risk of the development and emergence of resistance to newer therapies. Indeed, the time between deployment of a new antibiotic and the first documented failure of this treatment in humans due to resistance is much shorter for antibiotics than it is for vaccines, which can be frequently utilized for years and decades and confer effective protection. This rationale further supports our focus on vaccines, particularly in the context of antimicrobial resistance. I will focus now on two pathogens that are vaccine targets for neonatal sepsis at the Gates Foundation. Both were frequently identified in the systematic review that I mentioned earlier, Group B streptococcus and Klebsiella pneumoniae. In both cases, the vaccine approach of interest is a maternal vaccine. Maternal immunization, for those who may not be familiar, is a strategy of vaccination of pregnant women to provide protection to the mother, fetus, and infant through transplacental transfer of immunity. This is, of course, widely utilized in maternal vaccination for tetanus. First, in the case of Group B streptococcus, over 20 million women each year are colonized with GBS, pregnant women, and this colonization places women at greater risk for maternal death, is responsible for close to 60,000 stillbirths each year, over 300,000 cases of GBS, sepsis, and meningitis, with almost 100,000 infant deaths, as well as increased risk for long-term sequelae. We know that maternal colonization with Group B streptococcus is associated with increased risk for illness, both in the mother and then in the infant. We further know that there are key Group B streptococcus capsular serotypes, namely, of course, serotype 3 as the most dominant serotype that is detected globally, that colonizes a large proportion of pregnant women and is responsible for a large proportion of maternal and neonatal Group B streptococcus disease. Indeed, a pentavalent vaccine focusing on at least 5 serotypes of GBS would cover the great majority of GBS disease in both mothers and infants. And perhaps most importantly, we know that a maternal anti-GBS capsular antibody directed at these capsular polysaccharides can confer protection, and that has actually been demonstrated for multiple decades. Thus, there is now an active GBS vaccine development pipeline. Indeed, this table on this slide is now outdated, and some of these candidates have met barriers, and some of these candidates have now further advanced to clinical phase. Importantly, the vaccine development pipeline has been guided by the WHO Group B Streptococcus vaccine development roadmap, as well as their preferred product characteristics for a Group B Streptococcus vaccine that, if successful, would have the potential to result in significant reduction in stillbirths and early neonatal disease and death. In our last few minutes, I would like to focus to another priority pathogen, Klebsiella pneumoniae, which is a leading etiology of neonatal sepsis and deaths after the first 24 hours of life. The Child Health and Mortality Prevention Surveillance Platform, or CHAMPS, is funded by the Gates Foundation and works to collect clinical data, conduct verbal autopsies, perform laboratory tests for multiple pathogens, and examine tissue samples with both molecular and pathology techniques, and use these data to determine the specific causes of death in infants and children at sites in 7 countries in Africa and Asia. Among neonates, Klebsiella, in the evaluation of these combined data in deceased neonates, Klebsiella is determined to be in the causal chain of a rather astounding 44% of infectious deaths, and is in the causal chain of almost 30% of all-cause neonatal deaths occurring on days 2 to 28 of life. Klebsiella, unlike Group B Streptococcus, is not detected so frequently in the first 24 hours of life and is a negligible cause of stillbirths, but does account for an increasing and rather alarming proportion of late onset sepsis deaths. This has turned our attention to Klebsiella as a potential maternal vaccine target. As an encapsulated organism, Klebsiella also has both capsular K antigens and subcapsular O antigens. 5 of the 9 identified O antigen serotypes account for almost all neonatal sepsis cases for which we have serotype data globally. But capsular K antigens may differentially impact the accessibility of antibodies to effectively target these subcapsular O antigens. Our current analysis of serotype epidemiology suggests that 15 to 20 K serotypes may account for up to 80% of sepsis cases, neonatal sepsis cases, and a high valency O plus K antigen approach, conjugate vaccine approach, may be one to consider. Compared to Group B Streptococcus, we're at a much earlier stage with Klebsiella, and one of the key questions to which we are actively seeking an answer is whether maternal antibodies that are serotype specific to Klebsiella pneumoniae against capsular antigens confer protection. And we hope that we will be able to support the generation of data to answer this question in the coming several months to year. So in conclusion, I would like to underscore how neonatal sepsis continues to be an important contributor to mortality globally, and particularly in low and middle income countries. These sepsis cases are frequently due to drug-resistant pathogens, such as that seen in Klebsiella pneumoniae. But sepsis is associated with high mortality even in the absence of resistance, such as in the case of Group B Streptococcus, and all of this underscores the importance of prevention. Maternal vaccines are a key area for investigation and hold potential for prevention of etiologies of stillbirth as well as early and late onset sepsis. And we hope that this prevention approach can allow infants to not only survive, but remain on a trajectory of growth and resilience rather than that of vulnerability. I will stop there and thank you for your attention, and I'm happy to take questions.
Thank you, Dr. Padmini, for the great presentation. I encourage all the participants to ask questions using the chat box. I see a lot of nice remarks regarding the presentation. Meanwhile, waiting for the question, I will ask you, you spoke about, it's very interesting for me as a clinician about this possibility to vaccinate the pregnant women and to decrease the neonatal sepsis. And you spoke about vaccines against the Streptococcus and Klebsiella, but you showed us that more germs are associated with neonatal sepsis. So there are other vaccines for other germs on the pipeline. And do you think that in the future we'll have one combined for all these germs, not to have different vaccines?
Yeah, thank you, Daniela, for that question. I think you're right in pointing out that, of course, targeting a couple of pathogens doesn't address all of the etiologies of neonatal sepsis and related deaths. However, vaccine development, I think, is a long journey and an important and a long investment. And so we have arrived at focusing on these particular pathogens because of the significant burden of disease, particularly in the case of Klebsiella for late onset sepsis, accounting for such a high proportion of disease and deaths. We believe that a pathogen focused approach can really make a difference. And similarly, in the case of group B streptococcus, particularly considering stillbirths and very early onset sepsis, not to mention the potential protection for moms themselves. For other pathogens, I think it's a high bar to hope for a multi-pathogen vaccine approach, but certainly something that I know would be an ideal. In the meantime, I think I want to draw attention to some of the other approaches that are both pathogen specific as well as pathogen agnostics. In pathogen specific approaches, there are the potential for not only vaccines, where we have to be take into consideration not only the development timeline, the biological feasibility, the cost, as well as the implementation challenges of delivering multiple vaccines to moms in pregnancy. So the other potential to consider is immunizing infants, passive immunization of infants at birth with monoclonal antibodies. There again, I think we have to be careful to consider which pathogens might be appropriate targets where this is a pathogen that may cause later onset sepsis, and where targeting a specific epitope as a monoclonal antibody would still confer broad protection. And then finally, I'll just mention that there are also pathogen agnostic approaches. For example, the microbiome-based approaches, which I think Lisa will be talking about, which are not targeted at one specific pathogen. And I think a combination of these approaches will be necessary to truly make an impact.
Thank you. Now we have more questions. I will take one. There were in fact two related to how, when will be these vaccines available? You spoke about the vaccine for Streptococcus and Klebsiella. So are they used in some countries?
So no, unfortunately not. These are all still very much in development. Group B Streptococcus vaccine development is currently in clinical phase. So we would hope if the vaccine development pipeline is successful that we may see vaccine deployment in the coming 5 to 10 years. For Klebsiella, this is very much still at a preclinical stage. And as I mentioned, we still need, while we have compelling data to guide us to believe that Klebsiella is a worthwhile vaccine target because of burden of disease, we still need to generate the appropriate biological feasibility and plausibility data that anti-capsular antibodies would confer protection to the infant. So I think the timeline for a Klebsiella vaccine would still be on the order of at least a decade. Hopefully faster, but it's not something that is in current clinical use.
And how early this is a very interesting question, how early in the pregnancy we have to use these vaccines?
Right, no, that's a very good question. So for For group B's, for some of these pathogens, usually the targeted time period for maternal vaccination will be in the third trimester, early in the third trimester of pregnancy. So many of these vaccines are targeted between 28 and 34 or 36 weeks of gestational age, when we also expect that the transplacental transfer of antibodies will also be greatest. But still allow for maturation of antibodies, generation of antibodies, and then time enough for transfer to the infants.
Another question, and I wanted also to put this question, do you think this is a future also for adult sepsis to use vaccines? I'm asking, it was a question put by the participants, but we struggle here in this part of the world, in eastern part of Europe, sometimes with Klebsiella in the perioperative period, and I'm interested to know if in the future you think we'll have some this tool to vaccinate perioperatively people to prevent sepsis.
That's a very, very good question. And actually, I will say, especially for Klebsiella pneumonia and other multi-drug resistant pathogens, while we at the foundation are focused, of course, on the vulnerable neonates in low middle income countries, these same pathogens are, of course, causing sepsis in both high and low middle income countries in adult populations, particularly among those who are getting surgeries or have long-term stays in both acute facilities as well as long-term care facilities. And so there are other active vaccine development efforts for Klebsiella that are more focused on these populations. And I think ideally, we would see that the serotype epidemiology for Klebsiella is similar both in the neonates as well as in the adult populations, and then there would be a global and dual market use for a potentially effective vaccine.
Thank you, Dr. Padmini, for the presentation, and I thank all the participants for the questions. There are more questions, but unfortunately we have to move on. I hope that you'll have the opportunity after the meeting to see these questions and to post answers to the questions I didn't read during the meeting. So thank you again, and it's my great pleasure to introduce the next speaker, who is Dr. Mathias Pletz, professor for infectious disease and the head of the Institute for Infectious Diseases and Infection Control of the University Hospital in Jena, Germany. Professor Pletz is also the Deputy Director of the German Competence Network for Community-Acquired Pneumonia, a member of the Board of Directors of the German Society for Infectious Diseases and the German Sepsis Society, and he's also scientific advisor for the German Robert Koch Institute and a member of the Review Board of the German Research Foundation and the Swiss National Research Foundation. Professor Pletz, you have the floor.
Yeah, thank you, Daniela, for the kind introduction. Dear colleagues, I want to start right away. I want to talk about preventing influenza by improved vaccines, formulations, and post-exposure antivirals. I want to talk about 3 topics. First of all, I want to draw your attention that influenza is actually an underestimated healthcare-associated pathogen, and that we can prevent it by improved vaccines and particularly post-exposure antivirals, and I think this is something that is currently underused in clinical practice. We all know that influenza can cause pneumonia, and pneumonia is the most frequent focus in sepsis. However, most of us associate influenza with community-acquired pneumonia. And in fact, most of the major guidelines on hospital-acquired pneumonia don't even mention influenza, and I think this is just wrong. And here you can see the results of a study we did in our own hospital in the flu season 2014-2015. We analyzed all the ordered PCR tests for flu, and you can see we had a positivity rate of about 25%, which is actually quite high, and which would mean that we have actually ordered too few PCR tests. And 1/3 of those positive tests was caused by hospital-acquired influenza. And you can see that we have been very restrictive. You all know the definition of hospital-acquired means everything that occurs 48 hours after admission. The longest incubation time for influenza is 96 hours, and even using this very restrictive definition, we found that 1/3 of the influenza cases was hospital-acquired, and the case fatality rate was the same as community-acquired. And this has at least reshaped the German recommendation, the guideline for hospital-acquired pneumonia, and we have now the wording that routine testing for patients with hospital-acquired pneumonia should also be done for influenza, particularly for those on the ICU during the flu season. So what can we do to prevent influenza? And I think we are currently all spoiled when it comes to vaccines with the results of the COVID vaccines, with 90%, 95%, or even 80% efficacy or effectiveness. Here you can see the requirements of regulatory authorities regarding the license of new influenza vaccines. And they state that 70% seroprotection rate for those under 65 is enough for a new vaccine, and 60% for those over 65 years. You know, it's harder to get a good antibody response in the elderly. That's why you have this slight difference. So influenza vaccines are far from perfect and are inferior if we compare it, for instance, to the COVID vaccines. However, there have been some approaches to improve the immunogenicity and the effectiveness of influenza vaccines, particularly in the elderly and immunocompromised. One is adjuvanted vaccines like MF59. The idea of an adjuvant is that it will increase the recruitment of dendritic cells to the site of injection. Then there is an intradermal application by a microinjector. You can see it here, very short needle. The idea is basically the same. You inject the antigen into the dermis, and in the dermis we have an increased density of dendritic cells and a better presentation of the antigen. But for those two approaches, we have just data that they increase the antibody levels. The only approach where we have also clinical data is the high-dose approach. High-dose vaccines contain the 4-fold amount of the standard vaccines, and there are indeed 2 New England papers. One is from 2014, the other from 2017, and they compared high-dose vaccines with standard dose vaccines, and you could see that the high-dose vaccine decreased the breakthrough infections by roughly 30%. So from 1.9 to 1.4 in this study, and from 3.2 to 2.2 in the more recent study. Finally, and this is the main topic of my talk, I want to talk about post-exposure antivirals. But before I talk about antivirals, briefly one slide about the effects of the so-called non-pharmaceutical interventions, that is universal masking, distancing, and proper ventilation. And I think you all noticed that this time we didn't have any flu season. These are data from the Southern Hemisphere. You know, in the Southern Hemisphere, the flu season is between April and September. And in those 6 countries mentioned here, there was no flu season at all. And the same we see currently in the Northern Hemisphere. And this just proves how effective non-pharmaceutical measures can be. However, what do we do when we have an outbreak in a healthcare setting? And I said in the beginning that the opportunity of antiviral prophylaxis is underused, despite that there are recommendations to consider this. And this is the WHO recommendation for flu outbreaks in long-term care facility. And it states that antiviral prophylaxis should be considered, and decision for residents should be based on risk assessment, clinical judgment, and outbreak severity. However, still many physicians are reluctant when it comes to oseltamivir, the neuraminidase inhibitor, because it has the image of side effects combined with low effectiveness. And we know that if you give it late, then the effectiveness will decrease. However, in post-exposure prophylaxis, you usually give it very early, even before symptoms occur. And we have done a meta-analysis, and you can see that the effectiveness is actually 80 to 100% if you use it in the post-exposure setting. And this corresponds to a number needed to treat of 8 to 15 patients to prevent one case of influenza. The question is now how to use those antivirals as a post-exposure prophylaxis. And my personal experience is that they work actually best if you give it to everyone on the ward. If you have an outbreak on the ward, you can try to trace individual patients back, confirm the contact with the index case, and use it only in selected patients. However, this usually does not really terminate the outbreak. And I was quite happy when I prepared this talk to find this report from the Czech Republic. So they compared 3 nursing homes they were comparable regarding size and residence, and there were 3 outbreaks of influenza, and all the measures were the same except for the antiviral prophylaxis strategy. So in one nursing home, they just used oseltamivir for treatment, and the other, they used it also for prophylaxis in selected residents. And in the first nursing home, they used it after they could not contain the outbreak with non-pharmaceutical interventions for everyone, also for non-vaccinated staff members. And you can see that the outbreak was terminated very early when you used the oseltamivir broadly in residents and non-vaccinated staff members. And this actually mirrors the experience what I made in my own hospital. However, oseltamivir is also not the perfect drug, even if it works better in a post-exposure setting than in treatment. And there is a new drug now available called baloxavir, and baloxavir has a different mechanism of action. You can see here the influenza virus enters the host cell. It releases its RNA, the RNA is replicated, the virus is assembled, and then you have the budding process. And the last step of the budding process, the virus is attached to the host cell by neuramine. And the task of the neuraminidase is actually to cut this connection and release the virus. And this step is inhibited by oseltamivir. So it works quite late in the replication cycle. Baloxavir is different. Baloxavir works early in the replication cycle. After the RNA is released of the virus, it needs a start cap. And the start cap, it snatches from a cellular, from the host RNA. And this step, cutting the start ending from the host RNA and assembling it to the viral RNA, is inhibited by baloxavir. And baloxavir has also other advantages. It's shown in vitro that it's much more effective than oseltamivir. And also in clinical studies, it has been shown that it terminates the viral shedding already after 24 hours compared to 3 days for oseltamivir. And it has also good activity against influenza B. On top of this, it has also a better safety profile. In one phase 3 study, the side effects were basically the same as placebo. And it has a very long half-life and needs to be given only once. And so this all together makes it the ideal drug for post-exposure prophylaxis, low side effects, given only once, acting against influenza B, and terminates shedding already after 24 hours. And in fact, a couple of months ago, there was a study in the New England Journal testing this indication. It was a multicentric RCT in Japan. And 52 household contacts, including children. Actually, most of the participants were children between 12 and 18 years. Of 545 index patients were enrolled. Baloxavir was given once, mainly after 24 hours after the case of the index person was known. And you can see that the secondary transmissions in the household were significantly decreased from 13.6 to 1.9%, and this corresponds to an odds ratio of 0.14, so a decrease of secondary infections by 86%. And if you look in detail into the graph, you can see that most of the remaining infections in the baloxavir arm actually occurred after the 5th day. And I think this was a mistake in the design of the study, because when we use oseltamivir for prophylaxis, we give it, for instance, for 10 days. And baloxavir is also working with the long half-life for 5 days, so it should have actually been given a second time after 5 days, and then I assume there would be almost no secondary transmissions. So to sum up, I've shown you that influenza is an underestimated healthcare-associated pathogen. You should actively search for influenza during the flu season, also in hospital-acquired pneumonia. I've shown you that current standard vaccines are only moderately effective, but we have high-dose vaccines that are now available in Europe, and they have been available in the US already for a decade. And they can decrease the breakthrough infections by 1/3, particularly in the elderly. I've shown you that post-exposure prophylaxis with antivirals is a highly effective measure to terminate outbreaks in the healthcare setting. And compared to oseltamivir, this is currently the gold standard for post-exposure prophylaxis, the novel baloxavir may be a better tolerated option for post-exposure prophylaxis. Thank you for your attention.
Thank you, Professor Pletz, for the wonderful presentation. Very interesting. We have some questions. Do you think that the future vaccines combining SARS-CoV-2 spike protein or RNA sequence with respective influenza virus constituents would be possible and useful?
Actually, I hope that this will be the case, because I think the RNA vaccine platforms are just perfect. You can change them very quickly. You can change actually the RNA sequence on the computer, and the production of the vaccine is also a chemical process. You do not need to cultivate virus and to harvest virus, which is always prone to risk. As we have seen with AstraZeneca, sometimes they had problems to deliver. So this is a purely chemical process that can be controlled very nicely. And I've heard that you can add up to 3 different antigens into the RNA sequence. And I think this would make it a perfect vaccine, combined influenza, SARS-CoV-2, and maybe even RSV. But the future will show.
Thank you. There is another question about the resistance, if there is any resistance known to baloxavir.
Yeah, that's a good question indeed. There is resistance to baloxavir. However, we do not really know if this is clinically relevant at the moment. Resistance in viruses is different compared to resistance in bacteria. Resistance can evolve quickly. However, most resistant viruses have a decrease in biological fitness. That's why the evolvement of resistance is usually not as clinically relevant as for bacteria.
Thank you. And there is a question, do you think there is a link between bacterial equilibrium, immunity after vaccination, and virus?
It's a difficult question. I do not know
Yes.
if I got it right. The only thing what you can say is that the microbiota, this is known, has also an impact, for instance, on the response of the vaccine. So I think I've seen data, if you treat patients with antibiotics and you vaccinate them afterwards, then sometimes the vaccine response is decreased. So there is an interplay between the microbiota and the response to viruses as well.
Thank you so much, Professor Pletz, for the presentation, and thank you for the questions and answers. Unfortunately, we have to move on. It was a very interesting discussion. We have to move on, and I have a great pleasure to introduce a third speaker, is Lisa Pell, who is currently a senior research associate at the Center for Global Child Health at the Hospital for Sick Children in Toronto, Canada. She completed in Canada at the University of Toronto a PhD in the Department of Biochemistry and a postdoctoral research fellowship in the Department of Molecular Genetics. Please, Lisa, you have the floor.
Thank you very much, Daniela, for the introduction, and thank you to the conference organizers for inviting me to speak today about symbiotics and sepsis prevention in neonates. So today I will briefly review the current evidence for probiotic and/or symbiotic prevention for newborn sepsis. And I will also present an overview of what we call the Sepsis Study Research Platform, which has been established for the primary purpose of studying symbiotics for the prevention of severe infections during infancy. Now, there is a growing body of evidence towards the role of probiotics and/or symbiotics for the prevention of newborn sepsis. To ensure that we're all on the same page with respect to terminology, probiotics are live microorganisms that, when administered in adequate amounts, confer a health benefit to the host. Synbiotics are probiotics mixed with a prebiotic agent or a non-digestible agent that selectively promotes growth and or activity of probiotic bacteria. Now, recent meta-analyses have shown that probiotics significantly reduce the risk of late onset sepsis in preterm, very low birth weight infants with effect sizes ranging from 14 to 22%. In considering these results, it's very important to note the great deal of heterogeneity in the intervention type used between studies. So some of these studies explored the effect of a single probiotic, while others explored the effect of a mixture of different probiotics. And overall, a large variety of different species and strains have been explored. For these reasons, it's very difficult to provide a definitive recommendation as to the best probiotic strain or mixture of strains that would be most effective in reducing late onset sepsis. Now, if we take a step back and look at individual study results from 3 of the larger clinical trials run to date, heterogeneity in the intervention type administered, it persists, and the results we find are mixed. So for instance, on the left-hand panel, in the PRO-PREMS trial, which was conducted in Australia and New Zealand, they administered a cocktail of 3 different probiotics to infants that were less than 32 weeks gestational age and less than 1,500 grams at birth. Overall, they found no significant effect on late onset sepsis compared to the placebo group. However, in a subgroup analysis that was restricted to infants greater than or equal to 28 weeks gestation, there was a 49% reduction in late onset sepsis compared to the placebo group. Now, by contrast, in the PIPS trial on the right-hand panel, which was conducted in England, they administered a single strain probiotic to preterm infants, and they found no effect of the probiotic on culture-confirmed sepsis in the intervention group, again, compared to the placebo. Interestingly, they reported contamination in the placebo group, such that about 50% of newborns in the placebo group were actually colonized with the same type of probiotic bacteria as was administered to infants in the intervention group. Now, in contrast to these 2 trials, between 2008 and 2012, Panigrahi et al. Conducted a randomized, double-blind, placebo-controlled trial in rural India, in which they orally administered a symbiotic which contained Lactobacillus plantarum, strain ATCC 202195, plus fructooligosaccharides for 7 consecutive days, starting on day 2 to 4 of life, to infants who were greater than 2,000 grams at birth and greater than 35 weeks gestation. All of these infants enrolled in the study were followed prospectively until 18 months of age, and the study's primary outcome was a composite outcome of sepsis or death within 60 days of life. Now, the findings, which were published in Nature in 2017 August, were quite striking. They found a significant 40% reduction in their composite outcome of sepsis or death. However, there were very few deaths reported in the study, so this effect was entirely driven by an effect on sepsis. They also reported a 78% reduction in culture-positive sepsis, a 47% reduction in culture-negative sepsis, and a 34% reduction in lower respiratory tract infections. So not surprisingly, this study garnered a great deal of attention, and it ultimately led to the motivation behind the Synbiotics for the Early Prevention of Severe Infections in Infant Study, or sepsis study for short. The overarching aim of the sepsis study is to actually develop an adaptive clinical trial research platform in Dhaka, Bangladesh, that can be used to assess the safety and efficacy of promising probiotic and or symbiotic interventions for the prevention of severe infection and death in young infants, as well as the promotion of growth and effects on other infant health outcomes of interest. Ultimately, this infrastructure will enable the testing of any intervention to prevent neonatal sepsis and will allow us to conduct a high-fidelity replication of the Panigrahi et al. Clinical trial. It was conducted in India in order to extend the generalizability of their findings to another setting. Now, we've received funding from the Bill and Melinda Gates Foundation to launch up to 5 different studies within the sepsis study research platform, including an observational study, a phase 2 L plantarum trial, a phase 3 L plantarum trial, which will act as that replication of the Panigrahi et al. Study. We also have funding to launch up to 2 B. infantis trials. However, the decision as to whether these 2 studies will proceed depends on results that will be generated in earlier studies within the platform. Now, while each project within the platform has its own set of specific aims, consistencies do exist in how the various projects will be implemented across the research platform. And of particular relevance to this topic, some of those consistencies include the routine surveillance system for detecting clinical severe infection, our methods for ascertaining or confirming the presence of clinical severe infection, the pathways for triggering septic workup, as well as the definitions that we use for severe infection. Now, signs of possible clinical severe infection, or CSI for short, in our study can be detected at routinely scheduled in-person household visits, so conducted in the community by community health research workers, or at any time in between any scheduled visit by a phone call from a caregiver to a study worker. Detection of any sign of CSI will trigger a referral of that infant to the nearest study hospital for further assessment by a study medical officer. A case of CSI is confirmed when one of 6 signs of CSI, including poor feeding, lethargy, convulsions, severe chest indrawing, fever, or hypothermia, are documented by a study medical officer, and the treating physician actually confirms that there is sufficient general concern for sepsis or a serious bacterial infection to warrant a septic workup. In cases where the treating physician agrees that there is concern for sepsis or SBI, septic workup is triggered, which includes the collection of blood, a nasal swab, urine, stool, and if clinically indicated, CSF sample and or skin swab. If an infant bypasses our study surveillance system, such that a treating physician actually clinically diagnoses sepsis or SBI and prescribes 1 or more doses of parenteral antibiotics before assessment by a study medical officer, that infant may still be considered to have CSI, and pending timing and clinical features, septic workup may still be facilitated by the study team. Now, all of this information will be used to define severe infection by 60 days postnatal age, which, when combined with death within the first 60 days, will be the primary outcome in the L plantarum phase 3 trial, so that replication study, and a key secondary outcome in other studies that are being implemented within the research platform. Now, we've defined severe infection as at least one of those 6 signs of CSI that were mentioned on a previous slide, documented by a physician and or a physician diagnosis of sepsis or another SBI, and then at least one of the 2 following criteria: physician decision to admit to hospital, administration of at least 1 dose of parenteral antibiotics on the day when CSI is first ascertained, and treatment or physician intention to treat with parenteral antibiotics for at least 5 days, or blood and or CSF culture positive for a pathogenic organism. Now, this presentation has meant to provide you essentially with an idea of what's coming, or in other words, what we have planned, and more specifically, our approach towards detecting and defining cases of CSI and severe infection in a series of symbiotic or probiotic trials. Now, at present, the only study that has launched within the platform is the observational study, which launched in February of 2020. We've enrolled close to 800 of the anticipated 3,000 participants. And unfortunately, enrollment has had to be paused twice now due to the COVID-19 pandemic. We plan to launch the first L. plantarum trial in July of this year. And given that the sample size is only about 500 participants, we expect to complete enrollment in about 2 months' time. And after completion of enrollment into that phase 2 trial, we will be able to seamlessly transition towards launching the phase 3 L. plantarum replication trial due to the nature of this adaptive platform we've built. Now, before I conclude, I'd like to acknowledge the large group of investigators spanning multiple institutions in Bangladesh, Canada, and the United States, and the principal investigator on this study, Dr. Daniel Roth at the Hospital for Sick Children in Canada. I'd also like to acknowledge all sepsis study staff and participants, without whom none of this would be possible, and of course, support for this work from the Bill and Melinda Gates Foundation. At this time, I'd be happy to take any questions you may have.
Thank you, Lisa, for the very interesting presentation. Yes, there are some questions. One was related to the studies you presented, if they considered the mode of delivery, if there were normal vaginal delivery or C-sections.
Yeah, so that is a really important factor to consider, because mode of delivery can influence the microbiome of the infant, which is, of course, what these interventions target. So in the systematic reviews, the outcomes were, in none of the systematic reviews that I presented, the outcomes were not disaggregated by mode of delivery, but that is certainly one of many factors that can influence a probiotic's effectiveness. And I will say in the studies that we have planned, we have planned our sample sizes in a way that will allow us to do subgroup analyses based on mode of delivery.
I have a question about the safety. Do we have data about the safety of using symbiotics? I mean, and also we have to know the microbiota of the neonates in the region to adapt what kind of symbiotic we have to use?
Yeah, thanks for that question. It's an excellent question. So in terms of safety, probiotics are generally regarded as safe. And as an example, in the L. plantarum trial that was conducted in India, there were no cases of probiotic sepsis within that study, and very few adverse reactions. There were a few cases of gastrointestinal distension, but no serious adverse events linked to the probiotic. And your second question, Daniela, regarding the microbiome is an important one, and it's actually part of the reason we planned our study the way we did. So as I mentioned, we're starting with an observational study, and one of the primary aims of that study will actually allow us to better understand the baseline microbiome in this population, and will help to inform. So I mentioned whether or not we proceed with a B. infantis trial, for example. So it may turn out, if the absolute and relative abundance of B. infantis is very high in this population, it may suggest that that may not be the most appropriate probiotic to use in a future study.
Thank you so much. There are more questions. I still hope that there will be some possibility to see afterwards this question and to post some answers. Thank you, Lisa, for the presentation, and we have to move on. And the next speaker is Dominique Missiakas, who is a professor of microbiology and the director of the Howard T. Ricketts Laboratory, a regional biocontainment laboratory for infectious diseases research at the University of Chicago. She also is a co-founder of the Immune Arts with Olaf Schneewind in an effort to develop therapeutics and vaccines against Staphylococcus aureus. Please, Professor Missiakas, you have the floor.
Thank you. I hope you can hear me well. Thank you for this introduction, Daniela. And I want to thank the organizer for the opportunity to present our work on Staph aureus and describe the development of therapeutic antibodies to treat bloodstream infections with Staph aureus. As a brief introduction, Staph aureus infections are caused by both methicillin-sensitive and methicillin-resistant Staph aureus strains. They may be hospital-acquired or community acquired. In hospital settings, Staph infections account for about 1 to 3 of hospital admissions. They include surgical patients, indwelling catheters, ICU patients, mechanical ventilation, and including low birth weight neonates, which would be the topic that I will discuss today. So I think infections are not restricted to at-risk populations, such as immunocompromised, aging, or the very young. They also affect healthy humans. The highest risk for infection that we know is colonization, and about 30% of the human population is colonized, 2% of which is attributed to MRSA, the antibiotic resistant form. Skin soft tissue infection represent the most common form of infection, followed by bloodstream and lower respiratory tract infections. And even with surgical and antibiotic therapy, Staph bacteremia infection can reoccur. Staph aureus deploys many virulence factors to cause disease. Our group and our work has shown that staphylococcal protein A is key to immune evasion, and this factor, protein A, is found in both methicillin-sensitive and methicillin-resistant strains. So if this is Staph aureus in yellow here, Staphylococcus protein A is exposed on the surface, and it has two activities represented to the right. It binds immunoglobulin in the constant region of the FC region, as well in the Fab region of immunoglobulins, in particular of the VH3 clan. That is the conserved region that is normally forming the scaffold for antigen epitope binding. When SPA binds the constant region of immunoglobulin on the surface of the bacteria, this process blocks opsonization and uptake by phagocytes. When SPA binds, is released also by the bacterium, and it binds the B cell receptor of VH type, which represents about 50% of B cells in humans. It leads to the activation of these cells during infection and the production of VH3 type antibodies that are actually irrelevant for protection against Staph. So this B cell superantigen activity provides a very unique mechanism of immune evasion. As I said, you can see on these microscopic images here that SPA is not only conserved among strains, but it's abundantly covering the surface of these bacteria. And importantly, it's polyimmunogenic, or mammals actually cannot make antibodies against Staphylococcus protein A. Staphylococcal protein A is a modular protein that's made of 5 small immunoglobulin binding domains. Each one of them is formed of 3 alpha helices that fold in a small triple helical alpha bundle that can simultaneously bind the Fc gamma of the Fab region of antibodies. One can introduce 4 amino acid substitutions, 2 in red and 2 in green, The 2 in red will prevent FC binding to antibodies, and the 2 in green, the Fab binding to antibodies. As a consequence, you generate a non-toxigenic SPA variant. This non-toxigenic SPA variant can be used to immunize mammals and generate neutralizing antibodies or monoclonal antibodies that can outcompete SPA binding to the FC region and promote opsonophagocytic killing of Staph, as well as inhibit the VH3 Fab binding, allowing the host to make polyclonal antibodies when exposed to Staph. We have tested one such monoclonal antibody, 3F6, in several models of infection in mice and guinea pigs, including bacteremia caused by Staph bloodstream infection. Here, I want to describe an animal model for the neonatal Staph bloodstream infection. In this model, newborn mice that are 1 day old are passively immunized with an isotype control of the 3F6 antibody, and then they are challenged on day 2 with MRSA. This leads to a bloodstream dissemination with about, in these experiments, 80% survival following treatment with 3F6, as compared to 35 to 40% survival without treatment or with isotype control. Now, 6 weeks later, if we take these surviving animals and we challenge them with a lethal challenge of MRSA, 50% of animals that receive 3F6 as pups survive, while 0 survive in all other groups. They behave similarly to naive animals that were never exposed to Staph. We attribute the clearance in adult mice not to the long-lived 3F6 antibodies, but rather to the neutralization of the B-cell superantigen activity of protein A in pups. This conclusion is supported by the observation of the broad antibody response depicted at the bottom here, where we see an increase in antibody against multiple virulence factors of Staph listed on the x-axis and plotted as antibody fold increase following passive immunization with 3F6 as compared to isotype control. In pups, we attribute survival to the opsonization of bacteria by 3F6, which promoted the uptake and the killing by phagocytic cells. To look further into this process, we developed an ex vivo model of bloodstream infection. For this model, we use freshly drawn adult blood or cord blood as a surrogate for neonatal blood. In blood smears, we can see that Staph is either taken up by neutrophil or agglutinating into fibrin clots. It's a process driven by the pathogen through the secretion of coagulases. To measure bacterial replication in blood, what we do, we wash bacteria and incubate them at a multiplicity of infection of 10 bacteria to 1 neutrophil in the freshly drawn anticoagulated blood for an hour. And after 1 hour, host cells are lysed with saponin and the clots are digested with enzyme. These steps will release all staphylococci that have been plated for enumeration of viable bacteria as shown on the graph to the right. So I'm showing 3 cord samples, M4, M5, and M6, and you can see the killing capacity in the gray bars is the survival or replication of bacteria as compared to 100%, the initial inoculum. You can see that there is various ability to contain bacterial replication, but in general, Staphylococcus aureus replicates quite successfully. Addition of cytokeratin D in the grayer bar here, which is an actin polymerization inhibitor that blocks phagocytic uptake, shows further replication of bacteria. This reflects the intrinsic killing capacity of neutrophils in neonates or in the cord blood, which is comparable to what we have observed otherwise with adult neutrophils. Addition of human IgG3F6 antibody shown in light blue or darker blue for lower or higher concentration, as you can see, leads to a significant reduction in bacterial replication. So this is in agreement with the notion that 3x6 antibody promotes the phagocytic uptake and killing of Staph in the bloodstream. In summary, we propose that the conserved surface protein, staphylococcal protein A, is an important immune evasion factor of Staph. And we believe that therapeutic approaches based on antibodies against Staph must take into account SPA and thus must neutralize staphylococcal protein A. Phagocytes of humans, both adults and neonates, as modeled using cord blood, are able to take up Staph, and we propose that the opsonal phagocytic uptake can be boosted by anti-SPA antibodies for the elimination of bloodstream Staph bacteria. I will stop here and acknowledge contributors to this work. First and foremost, Olaf Schneewin, who initiated the studies on non-toxigenic SPA. Key contributor, past contributor in the laboratory at the University of Chicago, and current contributors, in particular Zinai Chen, Paola Noll Bernardino. The original monoclonal antibodies were generated at the Fitch monoclonal facility at the University of Chicago, and we have an ongoing collaboration with Patrick Wilson to analyze immune responses in humans following bloodstream Staph infection. Our work on SPA antibody has been funded for the last 10 years by NIAID and recent research with neonatal cord blood by the Bill and Melinda Gates Foundation. I thank you kindly for your attention.
Thank you very much for this very interesting presentation, Dr. Missiakas. There are some questions. One is regarding your opinion about the recently published Staphylococcus aureus vaccine candidate. It's about the vaccine, Staphylococcus aureus vaccine. So if you have an opinion on this.
I suppose we are referring to ISDB, which is a surface antigen, but a protein that blocks I1 uptake in Staph aureus and that failed. Probably it's a single antigen approach. Once again, it's a surface protein, so the antibody will compete with surface exposed protein A and might be neutralized by protein.
And another question is about could the 3F6 stop invasive disease in humans?
Yes, that is the goal, our hope. That's something that we would very much like to test.
Well, this is also my question. If in the future, because I'm a cardiac anesthesiologist, I will treat my patients with Staphylococcus mediastinitis with monoclonal antibiotics against the Staphylococcus. Yes. This is one of the goals?
That is one of the goals. I suppose that it will have to be combined therapy with antibiotics as well. But yes, during the bloodstream dissemination of Staph, we believe that 3F6 antibodies can block replication, promote uptake, and killing of Staph aureus.
Thank you very much, Professor Missiakas, for the presentations, and thank you for the questions. We have to move on, and I have the pleasure to introduce the next speaker, who is Dr. Christian Theilacker, who is working in Pfizer vaccines. Currently, he is acting as a global scientific affairs lead within the Vaccine Medical Development and Scientific Affairs Organization. And previously, he worked as assistant professor at the Albert Ludwig University in Freiburg and also at the University Medical Center Basel in Switzerland as a senior staff physician in the Department of Infectious Diseases and Hospital Epidemiology. Please, Dr. Theilacker, you have the floor.
Thank you very much, and thank you very much for your nice introduction. So today I would like to talk about infections after splenectomy. And without further ado, I just want to mention, yes, I work for Pfizer as my conflict of interest. I would like to review for 3 slides briefly the epidemiology of infections after splenectomy. So against our intuition, actually the incidence and the prevalence of asplenia and splenectomy is not that low. In fact, if you look at the prevalence of splenectomy and asplenia, this is somewhere between 50 and 100 in Europe, and that compares roughly to also the prevalence of HIV in the UK, for example, which is around 150 per 100,000. What has changed in recent years are the indications for splenectomy. It used to be that trauma is the dominating cause, but now it's splenectomies for neoplastic surgery and also for treatment of hematologic conditions such as ITB or sickle cell disease or thalassemia. Certainly, there are also underlying comorbidities which predispose to functional hypo or asplenia. Most relevant is, again, sickle cell disease, but also, for example, celiac disease or inflammatory bowel disease. If we look at the risk for infection after splenectomy or in asplenia, it is certainly the interval since splenectomy, with the 2 to 3 years post-splenectomy posing a vulnerable period with highly increased rate for severe infections. Age is an important risk modifier, as shown on the right-hand side, where you see risk ratios compared to the reference category of 35 to 49-year-olds. You can see that children clearly have an increased risk, especially in the category of non-hematologic malignancies. There are also certain underlying illnesses that are associated with a very high risk of infection after splenectomy, and that is, for example, morbus Hodgkin as a hematologic malignancy, also thalassemia or sickle cell disease. Previous episode, also strong predictor of increased risk, and also some case series indicating a highly increased risk in congenital asplenia. Another question is, what is the current microbiologic etiology of sepsis? There's actually some conflicting data around that, with some older case series dating back to the 1950s even, that showed that it's mainly pneumococcus, but also Haemophilus and meningococcus, and then more recent data showing that it's gram-negative. So that was basically the level of information that we reviewed in my former workplace in Freiburg, and decided, well, I think we need to do a prospective study to look how this is looking in today's world. And we did a prospective cohort study. We collected from all patients that we screened with sepsis and had a missing spleen. We collected microbiologic culture and antigen tests for pneumococcus, and we followed these patients up for 12 months. And in total, we were able to detect 52 OPSI cases. And as you can see on the right-hand side, the microbiology is very much in line to our learnings from these old studies, that basically it's the dominant cause is still pneumococcus, even though we now have vaccination programs in children for pneumococcus and changes in indications for splenectomy. It remains pneumococcus, that's the dominant cause. What we did not find, however, is any meningococcal infection, any H flu infection was not identified, but with a relatively small sample size, I have to admit. Okay, so probably in today's age, there is no talk that cannot have one slide on COVID. So I also was interested in splenectomy or asplenic states as a risk factor for COVID-19 infection. And I did find a very robust, large retrospective database study from the UK reviewing 17 million patients. And they found that basically there's no significant risk signal with a hazard ratio of 1.3 in asplenic patients compared to patients that have a spleen. And that's comparable to, for example, being male compared to being female for the risk of COVID-19 infection. So no truly increased risk, also not significant confidence intervals in this study. So what about direct evidence for effectiveness or efficacy of pneumococcal vaccination in the prevention of pneumococcal disease in this target group? Well, there are no specific studies that address this question, as there are, in fact, for almost none of the immunocompromising conditions. What we have, however, is increasing evidence for impact. So we have, for example, a very nice study from the US that documented with the introduction of the 7-valent conjugate vaccine in children with sickle cell disease in the US that there was a rate reduction of 93% to historic controls. We also have data from the Australia Spleen Register that with a multimodal intervention that also includes vaccination, the rate of invasive pneumococcal, meningococcal, or Haemophilus B disease was significantly reduced by roughly 70%. And also the experience from my former workplace in Freiburg, where we had a similar study design, although monocentric, where we really compared what is the pneumococcal infection risk in patients after they had received an intervention that included also vaccination compared to if they hadn't. And we only found one case of pneumococcal infection compared to 7 non-vaccinated patients. So increasing evidence also that vaccination does prevent pneumococcal disease, but I would like to mention that this is not the only element of the prevention. Very important is patient education, explaining the infection risk, giving alert cards, also antibiotic prophylaxis to evaluate patients for antibiotic prophylaxis and provide them with standby antibiotics, travel advice if they go to regions where malaria is endemic, and making patients aware that animal bites need attention of a physician because of the risk of capnocytophaga infections, which can be quite severe in this patient population. So this is just an example how alert cards could look like. This is what we designed in Freiburg when I was still working there, and I think this is now the 5th edition. Similar emergency cards are available also in many other countries. Timing of vaccination. Again, this is not like super high level evidence, but there are some studies that do suggest less than or lower immune responses in the immediate post-operative period. However, you should not delegate vaccination to the physician, to the GP, but rather give the vaccine before the patient leaves the hospitals, because what we did learn in our cohort study, if you delegate, usually vaccines are not administered. Also, you should avoid periods of immunosuppression, especially rituximab can deplete your B cells for up to 6 months. Corticosteroids in interval for 4 weeks, and after chemotherapy, 1 to 3 months is recommended. If patients are chronically immunosuppressed, you probably want to consider, even in adults, antibiotic prophylaxis. The vaccine recommendations you can see in this table are quite consistent, although there are some deviations between countries when it comes to pneumococcal vaccination and meningococcal vaccination. So what I will show you in the next slide are those recommendations where I also had been a part of developing them together with an expert group in Germany and the STIKO, the Standing Committee of Vaccination Recommendations in Germany. So what is recommended and for which we have stronger evidence to recommend this is pneumococcal vaccination. There are some uncertainties in this vaccination regimen. How often you should give revaccinations with the polysaccharide vaccines. In Germany, we recommend this every 6 years. In the US, this is only recommended once. Also, strong evidence to recommend meningococcal vaccines, both against the serogroups A, C, W, Y, and meninge B. Some questions around revaccination with Bactrim, with the MenB vaccine. And also, in most countries, Haemophilus influenza type B vaccination is recommended, as is influenza vaccination. One point I would like to make is that the pneumococcal conjugate vaccine now does not cover any longer. The most prevalent serotypes coverage is around 30%, but there are new developmental vaccines available. Because I work for one of the companies that produce these, I cannot actively talk about this until they are licensed, but you should need to know that there's a 15-valent and 20-valent conjugate vaccines that are in late stage clinical development, and they will come to market hopefully next year. Antibiotic prophylaxis, there is no evidence from clinical studies. This is all based on expert opinion. What experts and also Cochrane are aligned on, that children up to the year, up to 5 years of age should receive prophylaxis. Dosages are shown here. For older children, probably 3 years for this immediate risk period should also be covered by prophylaxis. For adults, no consensus. We in Germany do not recommend it. Many other countries in Europe do not recommend it. UK, Australia, and I think also in the US, this is recommended, but compliance is low. What is important, I think more important for adults, in my view, and many experts share this opinion, is that you give patients standby antibiotics, that you also tell them how to use it, and you renew their supplies when antibiotics are expiring. And one last word on vaccination. So it's fair to recommend vaccines, but you need to make sure that vaccination recommendations are implemented. And this is just one publication from our experience in Freiburg, where we compared patients that were just vaccinated according to local recommendations, or if you really send them to systematically to a dedicated outpatient clinic and give them vaccines, counsel them. And you can see that basically you can increase vaccination rates for all these vaccines that I have just shown you threefold. So compliance is increased a lot if you really have a system in place to implement your recommendations. And with that, I would like to close. Thank you.
Thank you, Dr. Theilacker, for the very interesting presentation. I don't see for the moment any question. I would like to ask you, in one of your table, you showed that antibiotic prophylaxis and vaccination, I think so, is recommended for children and selected adult patients. So what kind of adult patients you think should receive prophylaxis? You mentioned later that there are no recommendations in Germany, but however, what patients do you think need this prophylaxis?
Very good question. Again, this is expert opinion. What we in Germany had suggested in our guidelines is that patients with a very high risk of infection, such as stem cell transplant patients, should receive antibiotic prophylaxis. Also, patients with a previous episode of OPSI, of overwhelming post-splenectomy infections, we would consider for antibiotic prophylaxis, because we know that secondary and tertiary infections are quite frequent. So it's really patients with a chronic, highly immunocompromised state, on top of the Asplenia, or patients that have already experienced a sepsis episode.
Thank you. You said that this is an expert opinion, so we don't have data to know how much by prevention and vaccination we prevent infections in asplenic patients.
So I've shown you the data from the Victoria spleen register, and there they had a reduction of roughly 70% with this multimodal intervention of counseling, vaccination, antibiotic prophylaxis. Now, if you look at this study in more detail, you will notice that the periods are not quite comparable. There's a retrospective, there's a prospective arm. We had similar problems in our own cohort study. So if it's 70% or a little bit more, a little bit less, that is, I think, not quite sure, but that there is an impact. I think we are now increasingly certain that this does prevent.
We have a question from the audience. Do you recommend any vaccination available for COVID-19 for patients with splenectomy?
Yeah, so I had expected that question, and I really looked at different countries. I couldn't find much. Canada does recommend it, but all other major recommending bodies like ACRP, like STIKO, like JCVI in the UK, I could not find a reference to this risk group. That doesn't mean it doesn't exist. Maybe I just didn't catch my attention. There's so much, as you know, so much published these days on COVID, but I couldn't find any recommendations. I think they should be like according to the overall age and prioritization, patients should be vaccinated. But I think splenectomy by itself, at the moment of what we know, doesn't really pose an increased risk.
Thank you very much, Dr. Theilacker, for the presentation and discussion. So we have to move on to the next speaker. Before I introduce the next speaker, I would like to mention that session number 6 will start at in 6-7 minutes on another channel. So if you want to go to the next session, you can do. We are a little bit late. I'm sorry for this, but I think it was a wonderful session, and I have a great pleasure now to introduce the last speaker of the session, Professor Netea, who is infectious disease specialist and currently heading the Division of Experimental Medicine in the Department of Internal Medicine in Nijmegen University and Medical Center in Netherlands. He completed a PhD in Radboud University in Nijmegen, and also Professor Netea is a member of the Netherlands Royal Academy of Science. Professor Netea, you have the floor, please.
Thank you very much for the introduction, and thank you very much also to invite me. And I will like to go directly to the subject of my talk, which is repurposing known vaccines. This is something that I was asked to discuss in the coming 10 to 15 minutes. And what do I mean by that? And I would like to start my talk with an epidemiological observation that was made almost 100 years ago, when the Bacille Calmette-Guerin, BCG, the vaccine against tuberculosis, was introduced in Sweden. Dr. Carl Näslund, who was responsible for this vaccination program, has observed that the mortality in the children vaccinated with BCG decreased after the introduction of vaccines from 11% to 4%. So a very important reduction of childhood mortality. And that was before antibiotics were available. So a lot of children died of infections in those years. And that was not due to TB deaths, because those were less than 0.5% in this population. So he made this particular observation, and he said that probably BCG provokes a non-specific immunity. And this observation was made many times after the BCG was introduced in different countries. This is a systematic review from Higgins and colleagues in British Medical Journal in 2016, where he went through all the studies reporting the observation of all-cause mortality in the children with or without BCG, observing that in the majority of them, BCG was protecting. And this led to the concept that BCG as a live attenuated vaccine might have a non-specific protection given against an infection. But how could that work? How is it possible that BCG can protect against something else than tuberculosis itself? When we think at host defense against microorganisms, we have innate immune responses and we have adaptive immune responses. And the innate immune responses is what is happening in the first couple of hours and days after an infection. And this is supposed to be indiscriminate, non-specific, and lacking immunological memory. Whereas the T and B cells are the smart part of the immune system. They are induced specifically against a particular microorganisms, and it's building immunological memory. And that is what we induce with our vaccines. However, what we have observed in the last years is that innate immune responses, the myeloid cell responses such as monocyte and macrophages, can also be adaptive, can also be improved in their responsiveness. So for example, after BCG vaccination, when we isolate the monocytes from the circulation of the vaccinated individuals, they respond better not only against Mycobacterium tuberculosis, but they respond better against Staphylococcus, Candida albicans, and so on, against many other pathogens. So considering that, we ask ourselves, would it be possible that we can demonstrate in vivo, in a model of controlled infections in humans, that BCG can protect against another type of organisms, microorganism, and not only against mycobacteria? And we did that by administering healthy volunteers either placebo or BCG, and thereafter, 1 month later, yellow fever vaccine. Because yellow fever vaccine is an attenuated virus, and we can follow it by doing a PCR in the blood. And on day 5, when we have the maximum viremia in the blood, we have observed that the BCG vaccinated individuals had very strongly decreased viremia in their blood. So basically, BCG was able to protect against a viral infection. Now, how is that working? And I will not go through all the molecular mechanisms which we described in the last 7 or 8 years or so. But putting it very simple, is what is happening is that at the level of the DNA is very strongly, tightly packaged in the nucleus of a cell. And when a cell is activated, it is opening. There are chemical changes which take place in the chromatin, in the histones of the nucleosomes, which actually open the chromatin. When you read a book, you open it. That's exactly what the nucleus is doing when it needs to induce gene transcription, is opening the chromatin. And we always thought that after the infection, the chromatin in the innate immune cells goes back to normal. And it actually does. It becomes closed again. But there are some bookmarks. There are some chemical changes in the histones which stay there as a bookmark. So the next time then the cell is stimulated and we need to produce proteins which are necessary for host defense, the DNA can open at the right place much easier. It's like putting a bookmark, and the next time you need the book, you open it much quicker. And that results actually upon the re-stimulation of these innate immune cells to a better immune response and protection. So we wanted to assess whether this is possibly to happen also in an in vivo situation, with a concept that improving the innate immune response in the beginning, for example, by BCG vaccination, which will diminish the pathogen load, the viral load, the bacterial load, and so on. With low pathogen load in the circulation, we would have low symptoms, low inflammatory, low systemic inflammation, and the individual will survive. Whereas if that is not present, and we have low innate immune responses, there is high viremia, for example, or high bacteremia, inefficient systemic inflammation induced by this increased pathogen load, high severity, and death. And we performed a clinical trial in elderly individuals, and we randomized elderly people either to receive a placebo or to receive a BCG vaccination. And after that, we followed them for 1 year for the induction for susceptibility to infections. And what we have observed is that people vaccinated with BCG had significantly less infections, 40% less infections than the elderly vaccinated with placebo. And the type of infections that were protected against by the BCG vaccination were especially respiratory tract infections, approximately 80% less respiratory tract infections in BCG vaccinated individuals. So based on this, we have also looked whether other vaccines could induce also similar type of effects. And last year we have done a study looking at the influenza vaccination, whether it can induce also this long-term memory in innate immune responses, which we called trained immunity. And indeed, we observed the same thing. This is a very busy slide, but what we have observed that influenza vaccination also was able to strongly improve the response to other types of microorganisms, including against SARS-CoV-2. And thereafter, we assessed the COVID-19 incidence during both waves of the pandemics in the Netherlands. So we observed that actually in the vaccinated employees of our hospital, which is approximately 10,000, we are a university hospital with 10,000 employees, and approximately half of them got influenza vaccinated in the autumn of 2019. So we observed between March and June 2020, during the first wave of the pandemic in the Netherlands, that there were 30% less infections of COVID-19 in influenza vaccinated individuals in our hospital. And due to this fact, we also followed up thereafter the COVID-19 incidence in the individuals who were vaccinated in 2020 with influenza vaccine, and between October 2020 and March 2021, we have observed 51% less infections, less COVID-19 in influenza vaccinated individuals. This makes us to propose that these type of live attenuated microorganisms, whole organisms, because influenza was an inactivated virus basically, can mimic an infection, can induce epigenetic changes and functional changes in innate immune cells, and they can induce a non-specific protection against a different type of microorganisms. And we can use that in the future also, hopefully in future pandemics, to produce at least a partial protection of the population until specific vaccines, which are very important, can be developed after 1.5 years. So with that, I would like to thank you for attention, and also all the colleagues who participated in our study. Thank you.
Thank you very much, Professor Netea, for the wonderful presentation. There is a question, is BCG a good way to protect against tuberculosis, multi-drug resistant after COVID-19?
That we do not know. Of course, BCG is unfortunately a relatively poor vaccine against tuberculosis by itself, against pulmonary tuberculosis. Of course, now BCG revaccination, let's say after COVID-19, nobody has done these studies to see whether it would protect against MDR tuberculosis. But I do think that we need, I mean, BCG is important. It's a very important vaccine, still the only one against tuberculosis at this time, and we are still using it. It's one of the most used in the world. But I do think that we need to develop new and better vaccines against tuberculosis.
I have a question regarding the study you presented, I think Activate. It's important, I don't know if the patients you studied were vaccinated before the study with BCG in their life. Do you have this information? So was important if they were or not vaccinated sometime in their life with BCG?
This is a very important...
I know that not all countries are doing mass vaccination.
Yes, this is a very important question. And actually, I do think that it's important, although we don't have yet data from all the countries, but there is a tendency that in the Activate study, yes, the people were vaccinated. There was Greece when the study was performed. And at the time that our volunteers were born, Greece had a BCG vaccination program. So what we have done actually in Activate is in fact revaccination, because these were all individuals who got BCG at birth. We do observe a pattern actually, and you're perfectly right here, that we see more protection in the individuals who are revaccinated with BCG rather than a first vaccination with BCG. But we are now performing several trials, both in Africa and in Europe, and hopefully we'll have the answer soon during this year.
It's a question about the flu vaccination. Is this observed with live attenuated virus vaccine, or same with adenomultivalent flu virus?
This is inactivated virus that we have used. As far as I know, there were no clear studies with the live attenuated viruses, but there are several studies around the world from a number of countries, from United States, from Italy and Brazil, and all of them actually suggest various level of protection, anything between 20 and 60%. So we are going now to do actually a randomized trial in Brazil, where not all the people have access to vaccines, to see whether we can add these to our tools against COVID-19. So hopefully we will know that soon.
And another question, were other factors that differed between vaccinated and non-vaccinated employees other than the vaccination?
Well, not that we know, not in terms of, let's say, the basic demographics, but this is an observational trial, a study. This is not a randomized controlled trial, which is very important. The most important bias in such observational studies, that's why we would not recommend at this moment influenza vaccination, because it's not proven. It's just an indication that something is going on. But the most important bias is the healthy vaccinee bias. So the people who go, all our employees are offered influenza vaccination, but only half of them are getting vaccinated. So the question is, who are the people who get the vaccines, the people who are more aware of the importance of vaccination, who respect rules and so on. So it is very well possible that this contributed also, because those would be the people possibly also respect much better the social distancing rule, having a mask, washing their hands during the COVID-19 pandemic. So the healthy vaccinee bias could very well have played a role in our study. That's why we are doing now a placebo-controlled trial.
Thank you, Professor Netea. Wonderful discussion, and we could continue, but unfortunately we have to stop here. And I want to thank all the speakers for their wonderful presentations, fantastic talks, and I learned a lot. I thank all the participants for their questions, and I hope that we can post more questions and more answers in the future on the site. I recommend to go to the website and to sign the World Sepsis Declaration. Please use the social media, and be aware that next week we'll have the slides and the presentation on the website. And I want to thank you, to thank all the sponsors of the World Sepsis Congress. Thank you. I think you enjoyed the session, and I wish you to stay safe. Thank you.